Peds team, it's time to talk bugs, rashes, and shots. Welcome back to the deep dive.
Hey, everyone.
Today, we are tackling a pretty hefty stack of info, all focused squarely on pediatric communicable diseases.
That's right, we're going deep.
We are how they spread, vaccine basics, and really the essential nursing care you, as future RNs, absolutely need to know. And it's all pulled straight from a trusted source geared for you.
Exactly. Think of this deep dive like we're your guides through this material. There's a lot there.
For sure.
Our mission really is to help you pull out the most critical pieces, the insights that you'll actually use when you're caring for kids.
Yeah, cutting through the noise to get to what really matters for your practice.
Precisely.
Because, let's be real, pediatric infectious diseases, immunizations, it can feel overwhelming.
It's a huge topic.
But understanding this stuff isn't just, for an exam. It's fundamental. Keeping kids safe, stopping the spread, knowing what to do when you actually see these things.
Absolutely. It's about making it stick, making it make sense in the real world. Not just memorizing facts, but understanding the why and the how.
Okay, so where do we start? Foundation time.
Let's start with the basics. Immunity itself. How do we fight things off?
All right. The source lays out two main types, right? Active and passive.
Exactly. Active versus passive. So active immunity is when your own body does the work. It generates its own antibodies.
Like after you get sick.
Right. Naturally after an infection or, and this is key, we can stimulate it with a vaccine. The big thing here, it's generally long-lasting, often for life.
Okay, your body earns it. So passive is?
Passive is when you get antibodies from somewhere else. Like the classic example is a baby getting them from mom across the placenta.
Okay, so immediate protection.
Immediate, yes, but temporary. Only lasts weeks or months usually. You can also give passive immunity artificially, like with immune globulins, maybe after an exposure for short-term help.
Got it. Active is earned long-term. Passive is borrowed short-term. So vaccines. They're the smart way to get that active immunity without the disease.
That's the brilliance of them, exactly. Avoiding the risks of the actual illness.
Yeah.
And the source breaks down how they're made, different types.
Okay, what are the building blocks?
Well, you've got inactivated or killed vaccines. The bug is dead, but your immune system still recognizes it. Like the polio shot used here in the U.S., the IPV.
Dead bugs. Okay. Then there's live attenuated. What's that?
Attenuated just means weakened. So it's a live virus or bacteria, but it's been modified so it won't cause serious disease.
But it still wakes up the immune system.
Right. It replicates just enough to give a really strong, lasting immune response. Think MMR, varicella, those are live attenuated.
Weakened, not dead. Makes sense. What about something like DTaP? That's different again.
Yeah, that brings us to things like acellular and toxoid vaccines. Acellular means they just use pieces of the bug, not the whole thing, like the AP and DTaP, the acellular pertussis part, often safer.
It's to fragment. And toxoids?
Toxoids use inactivated toxins, so some bacteria cause harm through toxins they release. Tetanus and diphtheria vaccines use toxoids. The toxin is made harmless, but your body learns how to fight it.
Okay. And we've got subunit ones too. And mRNA.
Yep. Subunit uses just a specific piece, like a protein from the surface. Hepatitis B is a good example. And mRNA vaccines, they're newer. They teach your own cells how to make a piece of the virus protein, and then your immune system reacts to that protein.
Wow, lots of different strategies.
But the goal is the same. Show the immune system what to look for so it's ready if the real thing ever shows up.
And the impact.
Yeah?
The source really highlights this, thinking back before vaccines.
It's incredible, really. Diseases like diphtheria, it is terrifying, caused suffocation. Now, extremely rare in the U.S. thanks to vaccines.
And polio.
Polio, yeah.
Yeah.
Caused paralysis, death, just wiped out from most of the world now. It's easy to forget how bad these were because vaccines work so well.
A really powerful reminder.
But, as the source points out, we can't get complacent. Vigilance is key. And that brings up, well, the challenge of vaccine hesitancy.
Right, that's a big issue. And the source mentions that that retracted study linking MMR and autism.
Yes, that caused so much damage, and it's been thoroughly debunked. Multiple huge studies show absolutely no link. Zero.
The evidence is clear.
Crystal clear. And the takeaway for you as nurses, emphasized in the source, isn't just knowing the science, but understanding your role. Educating parents, building trust, addressing their concerns respectfully with facts, that's critical for keeping vaccination rates high enough to protect everyone.
That communication piece is huge. It's not just about giving the shot.
Not at all. It's about connection and education.
Okay, speaking of giving the shot, let's get practical. Administering immunizations. What are the key things nurses need to have locked down, according to the source?
All right, first up, Managing side effects. Mild stuff is common, right? Low fever, sore arm, bitter redness.
Yeah, happens all the time.
Parents can use acetaminophen or ibuprofen if the child seems really uncomfortable. But here's a nuance from the source. Routine use, just to prevent a fever, might actually blunt the immune response a tiny bit.
Oh, interesting. So use it for comfort, not automatically.
Exactly. And warm compresses can feel good on a sore spot.
Okay. What about when to vaccinate? Can you give shots if a kid has a cold?
Generally, yeah. Mild illness, like just sniffles, is usually fine. But if a child is moderately or severely ill, with or without a fever, hold off until they're better.
Got it. And the paperwork. This seems super important, the VIS.
Oh, absolute vital. Before any needle, the caregiver must get the vaccine information statement, the VIS. It explains the vaccine, the risks, benefits, side effects, what to look for.
And they have to sign off?
They get the VIS, you make sure they understand it, answer questions, then they sign a permission form. And it's great those VIS forms come in many languages. Helps immensely.
Definitely. What about reporting bad reactions?
If something more serious than mild local reaction happens, the source says the physician or NP reports it to VAERS, the Vaccine Adverse Event Reporting System. That's how we track potential safety issues.
Okay, VIS given, permission signed, shot administered, documentation time. What needs to be in that chart?
The source is very specific here, so listen up. You have to chart the vaccine lot number, the route, IMCQ oral, the exact site you used, the date, the manufacturer, the source of the vaccine, and the date you gave the VIS form.
Wow, that's detailed.
It is. And you keep copies of those signed permission forms too. Essential for tracking and safety.
Any universal red flags? Reasons not to give any vaccine.
The big one is a previous severe allergic reaction, like anaphylaxis, to that specific vaccine or one of its components. That's a hard stop.
Makes sense. And you mentioned routes, IMSQ, oral. Getting that right matters.
Absolutely. It affects absorption and effectiveness. DTaP-P, Hep B, PCV13 are usually IM, MMR, varicella RSQ, rotavirus is oral. IPV can be IM or SQ. You have to know which route for which vaccine. Non-negotiable.
Okay. Now, shots can be scary for kids and sometimes stressful for us. The source gives some great tips based on age.
Yeah, this is where that pediatric nursing art comes in. For babies, comfort holds, swaddling, pacifiers, maybe feeding during or right after. A little sucrose solution on the PASIC can help too. Distraction with soft talk or a toy.
And toddlers, they might put up more of a fight.
Keep explanations super simple. Comfort holds are key, having a parent help hold them securely. Distraction is your best friend. And importantly, manage your own anxiety and the parents. Kids totally feed off that. Lots of praise afterward helps too.
Good point about parental anxiety. What about school-age kids?
They can understand more, so you can talk them through it a bit beforehand. Engage them in distraction. Deep breaths, looking at a picture book, counting, telling a story, asking about their favorite game, giving them some control, like choosing which arm, can help.
Those are really practical tips. Okay, let's pivot and do a quick run through of the major vaccines covered in the source. Hit the high points, the stuff nurses really need to know.
All right, rapid fire essentials. Hepatitis B, usually given right at birth, within 24 hours ideally. Key point. If mom is Hep B positive, HBsAg+, baby needs the vaccine, and HBIG, Hep B immune globulin, within 12 hours. Big contraindication is the true yeast allergy. It's a 3-dose series.
Got it. HBIG for positive moms. What's next?
Hepatitis A. This starts at 12 months or older. 2 doses needed. Protects against hepatitis, often spread through contaminated food water.
Okay. DTaP-B.
DTaP-DT. Diphtheria, tetanus, pertussis. This is a cornerstone. Multiple doses in infancy and early childhood. Boost around 4-6 years. Side effects? Often some fussiness, soreness. That AP means a cellular pertussis, much safer than older, whole cell versions regarding a rare seizure risk. DT is for kids under 7 who have a contraindication to the pertussis part. Hib, Haemophilus influenza type B. This was a game changer. Prevented devastating bacterial meningitis, epiglottitis. It's a multi-dose series in infancy.
Huge win, that one. Rotavirus.
Rotavirus. This one's oral, a live vaccine. Prevents that really severe dehydrating diarrhea. Given in 2 or 3 doses, depending on the brand. Starting early, like 6-14 weeks. Big contraindications. History of intussusception, certain gut disorders, or SCID, severe combined immunodeficiency. Small risk of intussusception post-dose noted.
Okay, oral. Watch for gut history. Pneumococcal.
Pneumococcal, PCV13, PPSV23. PCV13 is the routine one for little kids. Protects against pneumococcal bacteria causing meningitis, pneumonia, ear infections, multi-dose series. PPSV23 is more for older, high-risk kids.
Polio.
IPV, polio. We use the inactivated version in the U.S. Much safer for immunocompromised folks than the old live oral one. 4 doses total.
Flu shot.
Influenza. Annual recommendation, everyone 6 months and up. Important note, kids 6 months through 8 years getting it for the first time need 2 doses that season, spaced about a month apart. There's the nasal spray option, too, for healthy kids over 2 without asthma or recent wheezing. And regarding egg allergy, only severe anaphylaxis is a contraindication now, not just hives.
Good update on the egg allergy, MMR.
MMR, measles, mumps, rubella. Live attenuated. First dose at 12 months or older, second dose usually before school, 4-6 years. Might see a mild rash or fever, maybe a week or 2 after. Key contraindications. Pregnancy, severe immunodeficiency, can give to HIV kids if their counts are okay. Be mindful of timing with antibody products or TB tests.
Varicella, chickenpox.
Varicella, also leave attenuated first dose 12 months plus non-second dose recommended. Side effects similar. Soreness, maybe a few chickenpox-like spots near the site. Source says cover that rash if it happens. Same big contraindications. Pregnancy, severe immunodeficiency. Watch timing with antiviral for antibody products. Breakthrough cases happen but are way milder.
Cover the rash. It. Meningococcal.
Meningococcal, ACWY and BP. Protects against bacterial meningitis. ACWY vaccine usually given at 11-12 years with a booster at 16. Men-B vaccine is for higher risk groups or can be offered to healthy older teens, young adults, 16-23, for short-term protection. Different schedules for Men-B. Tdap, tetanus, diphtheria, a cellular pertussis booster, usually given around 11-12 years. But here's a critical point the source highlights. Every pregnant person needs Tdap during each pregnancy, ideally between 27-36 weeks. This passes protection to the newborn before they can get vaccinated. Super important for preventing infant pertussis.
Wow, every pregnancy, that's key. Last one, HPV.
HPV, human papillomavirus, prevents infections that cause warts and several types of cancer. Recommended at 11-12 years, can start as young as 9. If started before 15, it's 2 doses. If 15 or older, it's 3 doses. Common side effect to watch for, fainting or syncope. The source says have them sit for 15 minutes after the shot.
Sit after HPV. Good tip. That's a fantastic rundown, really hitting those nurse-specific need-to-knows.
Yeah, knowing those little details, contraindications, timing, specific side effects, that's what makes your practice safe and effective.
Okay, so beyond giving shots, nurses are detectives when kids get sick, assessing a child who might have something contagious. What are the key history questions and exam clues from the source?
History is huge. You absolutely have to ask. Who have been around? Anyone sick at daycare, school, home? Timing is crucial. Does the symptom onset match incubation periods for common things? Have they ever had this illness before? And always ask, what's their immunization status?
Update or not, yeah.
And a major red flag the source emphasizes. Any baby under 2 months old with a fever of 100.4 Fahrenheit or 38 Celsius needs immediate medical evaluation. No exceptions.
Under 2 months, fever, CSP provider. Got it. What about physical clues? What should you look for?
Look for those prodromal signs. First, runny nose, cough, low fever, just acting off. That's often when they're most contagious, before the classic rash pops up.
Before you even know what it is.
Exactly. Then observe their behavior. Are they lethargic? Irritable. Look closely at any rashes, describe them. Flat macule, raised papule, pus fluid-filled vesicle. Feel for swollen lymph nodes. Check for fever, GI upset, sore throat, ear pain. Put all the pieces together.
History provides context, exam gives clues. Okay, now keeping everyone safe, infection control. Universal versus standard precautions. This trips people up sometimes.
Let's try to nail this. Universal precautions was the older term, focused mainly on blood-borne pathogens like HIV, protecting against blood and certain body fluids.
Right, and standard precautions.
Standard precautions is the current, broader approach. It applies to all patients in any healthcare setting. Assume everyone is potentially infectious. It includes everything from universal precautions, but expands it to all body fluids except sweat, non-intact skin, mucous membranes. Big emphasis on hand hygiene before and after every patient contact, plus safe handling of equipment and using appropriate isolation when needed. It's the default.
Standard is the baseline for everyone. Got it. Now, within standard precautions, the source talks about specific isolation types based on how things spread. Let's break those down with examples.
Okay, this is applying that transmission knowledge. Contact isolation. For stuff spread by touching the patient or things in their room. Requires gown and gloves. Think RSV, rotavirus, C. diff, impetigo, lice, scabies. Also, hepatitis A if the person is incontinent. The source notes varicella, chickenpox, and smallpox need contact plus airborne. Dedicated equipment is ideal.
Gown and gloves for contact. Okay.
Yeah.
Droplet.
Droplet isolation. For bugs spread by larger respiratory droplets, coughing, sneezing, these travel maybe 3 to 6 feet. Requires a surgical mask when you're close to the patient. Examples: influenza, pertussis, mumps, rubella, meningococcal meningitis, strep throat for the first 24 hours of antibiotics.
Mask for droplet.
Airborne isolation. This is for the really tiny particles that can hang in the air and travel longer distances. Requires a special fitted respirator mask like an N95 and a negative pressure room. Think measles, tuberculosis, TB. And again, varicella and smallpox fall here too. Huge point. Staff who aren't immune to measles or varicella should not care for those patients if possible.
Negative pressure room N95. That's serious stuff. Knowing which isolation for which bug is critical.
Absolutely fundamental for preventing spread in healthcare settings.
All right, let's dive into the specific diseases now. The source spotlights several common viral and bacterial ones. Can we pull out the key nursing points for each?
Let's do it, starting with viral players. Fifth disease, parvovirus B19, respiratory spread, classic slack cheeks, rash, then lacy rash, contagious before the rash, key nursing point. Big risk for pregnant women, can cause fetal hydrops, and can trigger a plastic crisis in kids with certain blood disorders. Droplet precautions if hospitalized immunocompromised.
Okay, slap cheeks, risk in pregnancy, hand, foot, and mouth.
Hand, foot, and mouth. Coxsackie enterovirus. Spreads all sorts of ways. Direct contact, droplets, fecal oral, painful sores in the mouth, spots on hands, feet. Virus sheds for weeks. Nursing focus. Hand washing, cleaning surfaces. Pain relief for those mouth sores is key for hydration. Supportive care. Hepatitis A. Fecal oral route. Often causes jaundice, but kids might just seem mildly ill. Most contagious before symptoms show. Nursing points. Contact isolation if they're incontinent. Immune globulin can help after exposure. Reportable disease. Think hygiene.
Hep B.
Hepatitis B. Blood and body fluids can become chronic, especially if infected as an infant. Nursing focus. Always use standard precautions. Educate families on preventing spread. No sharing razors, toothbrushes. Manage chronic disease if needed. Be aware of cultural factors, especially with immigrant children who may have higher rates.
Influenza.
Influenza, flu. Droplet and contact spread. Contagious even before symptoms start, up to a week after. Fever, cough, body aches, we know the drill. Nursing. Hospitalized kids need droplet isolation. Antivirals like Tamiflu work best if started within 48 hours. Push those annual flu shots.
Monello, the kissing disease.
Mononucleosis, EBV. Spread via saliva. Fatigue, bad sore throat, maybe swollen glands, and potentially an enlarged spleen. Virus sheds for months. Crucial nursing point. If the spleen is enlarged, absolute no-contact sports for usually 6 to 8 weeks. Risk of rupture is real. Also, fun fact, giving amoxicillin for a suspected strep throat when it's actually mono often causes a characteristic rash.
No football if you have mono.
Mumps, droplet spread, causes that classic puffy cheek, parotid gland swelling. Can have serious complications like meningitis or deafness, even sterility in males post-puberty. Nursing, droplet isolation. Watch for and manage complications promptly. Prevention via MMR is key. Or is RSV, respiratory syncytial virus. Spread by respiratory secretions, survives on surfaces. Causes a cold in older kids, adults, but can cause severe bronchiolitis and respiratory distress in infants. Sheds for weeks. Nursing. Contact isolation is vital. Gown, gloves, maybe mask if very close. Frequent close respiratory assessment is critical. High-risk babies might get palivizumab, Synagis for prevention. Teach parents those signs of respiratory distress, nasal flaring, retractions, grunting, fast breathing.
Watch those babies closely. Roseola.
Roseola, HHV6. Spread via saliva. The pattern is key. High fever for several days, then the fever breaks and a fine pink rash appears, mostly on the trunk. Nursing point. That high fever brings a risk of febrile seizures. Manage the fever.
Fever first, then rash. Rubella.
Rubella, German measles, airborne droplets. Generally a mild illness with a rash, the huge concern. Congenital rubella syndrome. If a pregnant woman gets it, especially early on, it can cause devastating birth defects, deafness, blindness, heart problems. Nursing focus. Emphasize MMR vaccination before pregnancy.
Protect the next generation. Rubiola. Real measles.
Rubiola, measles. Highly contagious. Airborne spread. Starts with the 3 C's. Cough, coryza, runny nose, conjunctivitis plus fever. Then Colpix scots, little white spots inside the mouth. Then the rash starts on the face head and spreads down. Nursing, strict airborne isolation. Measles can have severe complications, pneumonia, encephalitis, even death. Global immunization is critical. Immune globulin might be given after exposure to susceptible contacts.
Airborne Colpix spot spreads down. Varicella.
Chickenpox.
Varicella.
Spreads multiple ways. Direct contact with vesical fluid, respiratory secretions, and airborne. Super itchy rash with lesions in all stages at once. Spots, blisters, crusts. Contagious from a day before the rash until all lesions are crusted. Nursing. Strict contact A&D airborne isolation in the hospital. Safety alert. Never give aspirin or salicylate products due to Ray's syndrome risk. Manage the itching. Oatmeal baths, calamine. Remember the shingles connection later in life. Cover that injection site rash if it occurs.
Contact and airborne, no aspirin, COVID-19.
COVID-19. Source includes this too. Spread by mainly respiratory droplets aerosols. Presentation in kids varies wildly asymptomatic, mild cold, severe pneumonia, or that multisystem inflammatory syndrome, MISC. Nursing. Assess for fever, cough, shortness of breath, GI issues, loss of taste smell, rash. Testing. Supportive care. Isolation based on current guidelines. Educate on prevention, quarantine, recognizing severe signs by NC. It's still evolving.
Okay, that covers the major viral players. What about key bacterial ones?
Couple of big ones from the source. Conjunctivitis, pink eye, can be viral or bacterial. Bacterial usually has that thick, purulent eye discharge. Spreads easily by touching eye discharge, then touching surfaces or other people. Nursing. Teach proper hydropointment administration. Strict hand hygiene. Don't share towels. Keep hands away from eyes.
Gotta be careful with pink eye, pertussis.
Pertussis, whooping cough. Bordetella pertussis bacteria. Spread via respiratory secretions. Starts like a cold catarrhal stage, then progresses to those awful coughing fits, paroxysmal stage, where they cough and cough and cough, then take a forced breath in making that whoop sound. Often vomit after coughing. Can cause apnea, stop breathing, in young infants instead of the whoop. Contagious from the start for weeks if untreated. Nursing. Young infants often need hospitalization for respiratory support hydration. Antibiotics, like azithromycin, are crucial, especially if started early, within 3 weeks. Teach parents signs of distress dehydration, the key prevention. Tdap for teens, adults, and especially pregnant women to protect babies. The source includes signs of dehydration to teach.
That whoop sounds terrifying. Protect the babies. Strep throat.
Strep throat scarlet fever. Group A, strep bacteria. Spreads droplet contact, usually abrupt onset. Sore throat, fever, headache, maybe stomachache. Scarlet fever is strep throat with a characteristic rash, feels like sandpaper, often worse in folds like armpits, groin, plus a strawberry tongue. Young kids might just have fever debility, nasal discharge. Nursing. Need antibiotics, usually penicillin and amoxicillin, not just for comfort, but crucially to prevent serious complications like rheumatic fever, heart damage, or glomerulonephritis, kidney damage. Emphasize finishing the entire antibiotic course. They're not contagious after 24 hours on antibiotics. Push fluids, rest. Remind them to get a new toothbrush after they're better.
Finish the antibiotics. Prevent those complications. That breakdown disease by disease, highlighting the nursing actions is super helpful.
It really helps connect the dots between the disease process and what you actually do at the bedside or in the clinic.
And the source loops back, reinforcing caregiver education and safety alerts. These seem like constant themes.
They really are. You're constantly teaching, reiterating those emergency signs. Level breathing, color changes, pale blue, high fever with other worrying signs like stiff neck, major behavior changes, specific rashes like petechiae, tiny purple spots that don't blanch, signs of dehydration, no tears, dry mouth, sunken eyes, few wet diapers.
Those call 911 or go to the ED now signs.
Exactly. And the safety basics. Hand hygiene, hand hygiene, hand hygiene. The source calls it the key. The absolute no aspirin salicylates rule for viral illnesses due to Ray's. Cautioning against OTC cough cold meds for young kids. Supportive care like humidifiers and fluids is generally safer and often just as effective for symptoms.
Right. That supportive care, fever pain management, fluids, rest, maybe a humidifier that's your bread and butter for so many of these.
It really is. It underscores the whole nursing role. Sharp assessment, safe medication vaccine administration, correct precautions, supportive comfort measures, and being that vital educator and advocate for the child and family.
So, wrapping this deep dive up, we've covered a lot. Immunity basics, how vaccines work, how to give them safely and kindly, assessing sick kids, mastering infection control, and hitting those critical nursing points for key communicable diseases.
It's a comprehensive toolkit, pulling directly from your source material, designed to prepare you. This knowledge isn't just theoretical, it empowers your practice.
Absolutely. It helps you protect kids and communities. Okay, so here's a final thought for you, our listener, as you move forward in your nursing journey, something to reflect on.
Given the very real impact of these diseases we've discussed and the persistent challenge of vaccine hesitancy in some communities,
How will you personally use this deep dive into the science, drawing from your trusted sources, to build trust with families and effectively promote health where you work?
how do you translate facts into connection and understanding? It's a big part of the job,
Definitely something to think about.
for sure.
Stay sharp, stay safe. See you in the next one.